Welcome to the Heart of Prevention, helping clinicians stay up to date on preventive cardiology. This show features leading experts discussing real-world strategies to prevent heart disease, from lifestyle changes like diet and exercise to medical treatments, including new therapies. Whether you're a medical student, resident, or practicing clinician, this podcast challenges, informs, and enhances your approach to cardiovascular disease prevention. The Heart of Prevention, keeping hearts healthy one episode at a time. I'm Dr. Michael Shapiro, President of the American Society for Preventive Cardiology, and now here's your host, Dr. Keerthana Pakanati.
Dr. Mehta, Dr. Afaq, welcome to the Heart of Prevention.
Thank you, Keerthana. It's an absolute pleasure.
Thank you for having us.
So I'm super excited. This episode has been long requested, and we have a lot to get into. But before that, let me take a minute to tell our listeners about our esteemed guests for today's episode. So Dr. Anurag Mehta is an assistant professor of medicine in the Division of Cardiology at Emory University School of Medicine. He's a preventive cardiologist at the Emory Heart and Vascular Center. He's on the board of directors for the American Society of Preventive Cardiology, and he's a co-chair of SAPNA, which is the South Asian Prevention Network at ASPC. Our other guest, Dr. Mazhar Afaq, is also the co-chair of the South Asian Prevention Network at ASPC. He's a director of preventive cardiology and associate professor of cardiovascular medicine at the University of Kansas Health System. Big topic, lots of things to cover, lots of stuff coming kind of out the woodworks as we learn more about South Asian cardiovascular health. But before we get into it, right off the bat, South Asians known to have higher cardiovascular risk at younger ages. What are the key drivers behind this? Can you break it down for some of the listeners that may not be aware of that? And we'll start with Dr. Mehta.
Absolutely, Keerthana. I think that it is a well-known fact that we've realized over the past few decades that South Asians have a 2 to 4-fold higher risk of cardiovascular disease. And cardiovascular disease being multifactorial in nature, I think there are multiple risk factors that are responsible for this. There is the genetic susceptibility for cardiovascular disease, which I think plays a key role. But in addition to that, the traditional cardiovascular risk factors, including atherogenic dyslipidemia, glucose intolerance, type 2 diabetes, hypertension, smoking, these tend to be highly prevalent in South Asian communities, particularly diabetes. And I think that is a major driver for cardiovascular risk.
Thank you. Dr. Afaq, anything to add?
Just exactly as Anurag was saying, just definitely more predisposition to diabetes, earlier heart attacks, dyslipidemia, all of the traditional risk factors, which are just accelerated in South Asians, it seems.
And so we're kind of talking about the implications for cardiometabolic risk here. We know that they have increased risk for things like diabetes and dyslipidemia earlier. What is the South Asian phenotype, and how do you really describe that and in an explanation to try to understand why they have earlier cardiometabolic risk? And we'll start with Dr. Afaq.
The phenotype, many people would have heard this term, is a thin fat or skinny fat as a description. So definitely in the South Asian population, they have lower BMIs, but higher body fat. That can be higher visceral fat, it could be higher intramuscular fat, hepatic fat. So all of these things are certainly increased in South Asians. And this then comes with that additional risk of increased insulin resistance, hyperinsulinemia. So all of these kind of metabolic risk like confounders come all together in one. So that would be the type of person who we would see and say, okay, when you're seeing a South Asian patient or person, this is what they come with. And even though BMI might look fine, there's more going on underneath.
Yeah, absolutely. Dr. Mehta?
I would completely agree with Maz. I think that the external appearance tends to be deceptive. You would not expect somebody with that kind of clinically apparent phenotype to have aggressive atherosclerosis, have a heart attack at a very young age. I will add one thing that we are learning now from the lens of the epidemiology of diabetes in South Asians. An important phenotype or a cluster in this population is one where there is insulin deficiency instead of the traditional insulin resistance that we think about that comes with obesity. And that kind of ties into the functionality of the pancreatic beta cells. So hypoinsulinemia, the ability of the pancreas to meet the metabolic demands gets overwhelmed faster in South Asians, and that predisposes you to impaired glucose tolerance, prediabetes, diabetes, and I think that is an important driver of cardiovascular risk as well.
Yeah, thank you for bringing that up. I feel like that adds to the point that we're just constantly learning at a really rapid rate of as we try to understand why, this predisposition even exists. I'd like to pivot a little bit to talk about, cultural beliefs and health perceptions can really influence how people seek care and their impression of that. And how do you think in the South Asian community specifically, obviously we're talking on a grander scale. We know that there are many different smaller subgroups within the South Asian category. But for the sake of the conversation, keeping it broad, how do you find that those cultural beliefs and health perceptions can influence how, say, our grandparents or even our parents are seeking care? And we'll start with Dr. Mehta.
I think, Keerthana, in my experience, especially with people of the generation, as you mentioned, parents and grandparents, I feel like there's a couple of issues that are recurring themes for me. One of them is the deterministic nature of health and lifespan. There is a perception that if something is meant to happen to my health, particularly cardiovascular disease, then it is going to happen regardless of any kind of interventions that I would do in terms of changing my lifestyle, exercise, diet, taking medications, for example. That's one. And second is a something that is, I feel that something that is deep seated is a mistrust in what we is modern medicine or Western medicine. People, especially, again, an older generation likes to avoid using medications to help their cardiometabolic risk, lipid management, etc. And they want to focus on more so solutions that are rooted in, for example, Ayurveda or other herbal remedies. So I think those, for me, those health perceptions and the desire not to seek medical care are very relevant and important in terms of managing cardiac risk.
Yeah, I think the point you made about the deterministic effects, I mean, I could even think in my head in the language my family speaks of what that phrase looks like of like, oh, if it's going to happen, it needs to happen. And I've heard it over and over again. And I think that's such a big thing to bring to the forefront. So I think that's something that we share across the board. Dr. Afek, what are your thoughts?
I think certainly I'm lucky right now. Actually, my father is living with us, so I've got a real time experience of between 85 and 87-year-old gentleman who has the mindset of exercise is not necessarily important. It was never a thing in that generation, and so I think having someone like him to start exercising to build up core strength to stay active. It's tough to do, but then when I look at everybody who's from like in the young professionals to all the way to older South Asians, exercise is certainly a big thing. If I look at my kids' age, they're always bulking or something. There's always something going on. They're like, exercise is a big part, but, will it stay throughout their, professional lives when life gets busy? It's hard, but I think generally exercise has not been felt to be an important part of lifestyle, even to some point, people thinking that it might be harmful. It might be, you'll injure yourself. Don't do that, right? So that's one thing. And also the perception of what exercise is. To taking a stroll, leisurely walk is not, it's good, it's better than not, but it's not like exercise, getting your heart rate up. So whenever I'm trying to speak to somebody about this, I'll say just at least get to the point where you're breathless, like at least so that if someone stops you and asks you for direction, you don't just have a full-fledged conversation with them. You say, "Oh, let me just catch my breath." So that's the kind of level of at least exertion happening regularly. We talked about in our episodes on Diwali and Ramadan, like just that kind of mindset of how parts. I mean, it's such a rich culture. How parts of that culture can be kind of maybe fine tuned. You're not going to it would be wrong to change things dramatically, otherwise you lose the beauty. But there's certainly things that we can do. And I'm sorry, I think I went off tangent and waffled a bit, but
No, I love it. I think that's so important because there are so many facets to how you answer this question. And you even touched upon like the diaspora, right? Like our parents that moved here, or my parents that moved here. And then I am like considered first gen born and raised here. Like there's such a different cultural identity and a different system of beliefs between that. And we're maybe more fortunate that we're able to put priorities towards like working out and working on our health. Whereas when our parents were here, it was like they were coming here and they were trying to build a better life for us and they didn't have time for that, or they thought they didn't have time for that. And so it's recognizing that now in their 60s, trying to teach them to like take care of themselves when they really have just been so focused on taking care of everyone else around them, or at least that's what I think of. And I think your point about the exercise is so true, because the after meal walk is just such a cultural thing, but they're really just like kind of leisurely roaming the neighborhood. But that is actually very relevant, I think.
I would completely agree. I think the other thing that gets ignored is exactly what you mentioned, Keerthana, is the caretaker burden, especially for people who, immigrated to the United States or, for example, any other country as well. They're so focused on providing for their family, building their career, better future for their children, that these things kind of take a back seat. And
Totally.
and something that comes up in 50s and 60s and maybe even 70s is that, there's a time that has been lost, and kind of bringing back that focus on cardiovascular health it can be challenging.
Yeah, that's a great point, considering it time lost and trying to regroup and redirect. And so, when that South Asian patient shows up in your clinic, no matter what age they are, let's talk a little bit about traditional risk calculators and how in the past we know that maybe they underestimated cardiovascular risk in South Asians and what we should be doing to adjust our assessments. We briefly touched upon like the skinny fat and the normal BMI, but how do we in clinic really understand South Asians' cardiovascular risk, and what risk calculators should we be using, and what's y'all's approach? And we'll start with Dr. Afaq.
It see somebody like this, I'd say, traditional risk factors are just as your foundation. So we go through all of the traditional risk factors as a baseline. Um, but yes, we've known that pooled cohort equations, the Framingham risk scores, these have all been traditionally known to underestimate. And in fact, you know, as experts have said that increase, adjust it 1.4, 1.5 times higher than what the calculator shows, right? If you're using an equation. The Prevent Now calculator certainly is showing, I think, again, it's still very relatively recent, some improvement in that and estimation. But I think what ends up happening is that our visits end up being first and foremost educational, because it will be that visit where you honestly shine a light on something that somebody would be thinking was just part of life or normal. So we start talking about the risk factors, we start talking about where they are, and then we start saying is that, okay, if we look at your potential risk, it's higher than what these calculators show. And if the calculator is already showing that, look, you're at high risk, we should be talking about aggressive interventions, about aggressive prevention strategies. So the conversation, again, it's so age dependent. And that's one thing that I think we have to be aware of, is that which stage of life are you speaking to somebody on? And you will connect with them in a different way if you can relate to their stage of life. So my feeling usually is that we'll put the data down, because we don't have a calculator which is dedicated to South Asian risk. I mean, latest guidelines now it's comfortably recognized that, being of South Asian heritage enhances your risk, as a risk enhancer. But there is no strong, in fact, maybe actually in the UK there is a Q risk calculator, I think, and that uses South Asian ethnicity as part of the calculator. But remember, then we've got different percentages, your 3%, 5%, and that calculator 10, 20%. So patients could end up being very confused as to, hold on, what is my percentage? Am I low risk on this calculator? I'm intermediate risk on another. And that's why I think sharing more data, but then still using the art of medicine to say that, look, this is what we think. And then where are you at with this? Do you kind of fit with this mindset? Are you ready for some changes? Where do we go from here?
I think across the board, no matter what we're talking about, it always comes down to the patient and meeting them where they're at, seeking to understand what they know about what's going on before you kind of bombard them with all this information, especially if they're kind of coming in with a blank slate for you. Dr. Mehta, what are your thoughts?
I agree. I completely agree with Maz. And one thing which I do kind of whenever I'm meeting somebody who's South Asian in my clinic is that I'm a little bit more aggressive in terms of assessing their subclinical atherosclerosis risk. So my threshold for considering a calcium score, for example, is lower. And that comes from the fact that, the previous guidelines, the 2018 ones, and obviously the most recent ones as well, have recognized South Asian ancestry as a risk enhancer for atherosclerotic cardiovascular disease. With the most recent guidelines, coronary calcium scoring has been promoted to level 1 category of evidence as well. So I tend to be a little bit more aggressive. People in their 30s, for example, if they're coming and seeing me for, family history of heart disease, cardiometabolic risk assessment, I check their calcium score to look for any hint of calcified atherosclerosis, because as you all know, subclinical plaque develops first, but it takes months and years for it to calcify. And even if you're picking up a calcium score of 1, that means that there has been atherosclerosis going on for a while, and we need to jump on it and start addressing the risk factors.
Yeah, absolutely. Thank you for that. In that note, if you have someone in clinic who's coming in, and this is probably the art of medicine that Dr. Afak mentioned, but for some South Asian patients, they have been told so long for what the idea of what, the heart patient looks like, right? And so for these patients who appear low risk from the outside, you talked a little bit, Dr. Mehta, about the calcium score and like how we kind of bring them into that. But walk me through a little bit about how you counsel these patients that are like, well, I feel like I'm doing everything right and I, like I am in the normal BMI and I look okay. And, where do you meet them and how do you kind of encourage them to understand more about their health, especially with those secondary modalities like imaging?
Yeah, and that, Keerthana, this is a clinical question that comes up frequently in my practice. I would say approximately 10% of my practice is South Asian. So people who come in, normal BMI, trying to take good care of their health, eating healthy foods, exercising regularly, and then seeking to understand where their risk is for cardiovascular disease at this time point, and perhaps more importantly, what does it stem from? So I do a comprehensive assessment in terms of I'll be checking their lipid panel, their ApoB, their lipoprotein A level. I'll be checking their hemoglobin A1C, fasting blood sugar levels, along with the other assessments, kidney function, renal function, etc. And then when I sit down with my patient, I speak with them that, hey, this is something that we've known about for several years now. It is incompletely understood, but what we become really good at is understand where you are now, but our future risk is, or our future science is going to inform the basis for that risk. And I try to counsel them about, further lifestyle enhancements in terms of aerobic activity, muscle strength training, a diet that is aligned with the Mediterranean style. And that is my clinical approach in terms of guiding them.
Thank you. Dr. Afek, what about you?
Would say that just helping us all understand, because this isn't, I think well kind of registered the fact that, a BMI of 23 is not okay in a South Asian, or, above 23. And above 27 and a half, that's obesity. So this ends up becoming like Mark, and I don't like using the word obese with patients, but I do use it as a medical description because that's what they're going to see on their chart, and that's their medical diagnosis from that way. And sometimes it does resonate, but the point is that even at 27 and a half, then that's obese category. So that sometimes certainly does register. Waist circumferences, the lower waist circumference as opposed to what is recognized in kind of those of European descent. These are things which we kind of measure, highlight, talk about. And, Anurag mentioned lipoprotein A. Definitely, 1 in 4 will have a number higher than 50 milligrams per deciliter. And so these are things which we're getting better across the board about checking lipoprotein A on everybody, but specifically on South Asian population. I think that's something that we do fairly regularly.
Yeah, thank you. So we're going to take a little pause here and do a quick round of a rapid fire. So I'm going to ask a question and then you feel free to just kind of shout out your first answer. Although most of the times the guests are too polite and they just take turns answering it, which is fine too. But the first question is, what is your go-to South Asian comfort food? And then what is your cardiology approved twist on it? Either of y'all can take it.
Uh, all right, I'll go first. Mine is pretty bad. So I'm Punjabi, and it's a dish called chole bhature, and that is my absolute favorite comfort food. And I've thought about it for a while, why this is the case, and the psychological underpinning is that when I was young, very young, for some reason my parents wouldn't allow me to eat that. I don't know why, and I need to kind of go back and ask them. And but there was a time in my life, and I think I was 13 or 14. I had my bicycle at that time, and I would use it to commute to school. And a bunch of us friends would get together and go to the shop in my little town that would make the best chole bhature. And that for me was that click. And I was like, this is the thing that is going to be my favorite food for the rest of my life. So I try to eat it maybe once every other month or so. There's some good places in Atlanta that make it. Unfortunately, there is no cardiology approved twist for it.
Maybe it's moderation. It seems like your cardiology twist is to not eat it every day as much as we'd love to.
Yeah. Yes, I could very easily eat it every day, no doubt about that, and my health would just completely deteriorate. One twist that I'm thinking is that just eat the chickpeas, that's the chole, and don't eat the bhature, which is the fried bread, which is, obviously the most important thing. So that's my take.
I love it. Dr. Afaq, what about you?
Well, Anurag, you were cycling to school, man. That counts for a lot.
Yeah. Yeah. This is like, I want to say 2-3 miles. A bunch of us friends would go every day in the heat. This was like close to so I was in Haryana. It's close to the desert, the Thar Desert in Rajasthan. So yeah, I was getting my cardio at the time.
I think that negates the effects. I think that would have been okay. Fantastic. I think from my standpoint, I don't know if comfort foods are meant to be readily available or not, like easily. I think my food that I love is like kofte, and then kofte and roti, which is chapati or flatbread. So kofte being like a meatball in a curry sauce. So I do like that. I've always liked it. I've liked it growing up. My mum made it, and sadly she's passed. And so enjoy your mum's cooking when you can, right? So these are that's just one thing that I certainly miss. But the cardiology, healthy kind of version of that. And actually, my wife made this one time, and I was shocked because I thought that why would you change a tried and tested recipe? Right? It was fantastic because she actually instead of mincemeat, she used cauliflower. I think cauliflower maybe, and they were actually really, really lovely. So I would say is that there's always alternatives, certainly, that we can experiment with and try. But she made cauliflower kofta and roti. I think if you're going to change something from the stone ground wheat flour, would be millet seed. I think that would be the alternate. And I've tried to make that, and it doesn't come out the same. And it's like, so I'm sure that there's techniques of making better flatbread roti.
I will say you didn't say rice though, so I feel like we kind of already are, nobody said rice.
My daughter would have said rice and dal. She would have right. She's that's one of her things.
Well, I love it. Now I'm hungry, but what are 3 actionable steps you would tell your family members? 3 things they can do to decrease their cardiovascular risk.
All right. I would say 3 things. I would say first thing is to stay mobile and actually exercise in a way that is improving not just your heart rate, but your muscle strength. So that would be one thing. So exercise does not mean that casual stroll, but really increase your heart rate and your muscle strength by doing some type of resistance. A second thing is just be mindful of what is going in your mouth, like try and avoid that late night, we're big tea drinkers, and like there's always something with tea. And it's
Yes.
that with tea thing that we should really be mindful of, is that, did I really need that? Was there a healthier alternative? I'm not saying don't have tea, don't have the, traditionally we call it chai, like the part with tea. Don't have sugars foods late at night. We often drink tea in the evening, completely immune to caffeine, but I would say that. Just third thing, somehow reduce your stress. Reduce, if you can, and that's easier said than done, but is there something that you can just stop worrying about? That would be important. Share your burdens, reduce your stress. That's it.
I should have asked, what is your chai snack alternative to all the
Oh,
other things I'm thinking of that we eat?
my gosh.
Dr. Mehta, what are your 3 steps that you give your family members or your
They
patients that are
overlap.
basically like your family?
Yeah, yeah. I overlap in terms of recommendations with Maz. I think these are very, very important. I have a strong family history of cardiovascular disease, Keerthana, and I think for me, something that I add on is to bug them a lot and hold them responsible for taking their medications for my family. And it is tough. It is so tough. But, I speak with them every day. And I would say once or twice a week, I ask them, did you take your statin? Did you take your blood pressure pill, etc.? When is your next checkup with your primary care doctor? When is when are you getting your labs drawn for this year and things like that? So that is one thing which I would add, in terms of how to help my family where I hold them responsible and I keep bugging them. And I think that's a good thing.
Yeah, that's harder. Easier said than done for sure.
For sure.
What is one risk factor that you think we're under recognizing that maybe we're learning more about now, but what's one risk factor you think we've under recognized for a long time in South Asians or we're continuing to under recognize?
I will have a shameless plug here, Keerthana. Recently got a grant approved to study lipoprotein A in a sample of nearly 20,000 South Asians who are living in India. And I think that truly understanding, having a very deep and clear understanding of lipoprotein A is missing as of today. And I'm hoping to solve or, close that knowledge gap in terms of how does it associate with cardiovascular risk in terms of clinical events, subclinical atherosclerosis, how does it perform in addition to, the usual traditional cardiovascular risk calculators that we have. So that to me is something that I'm very passionate about and something that I will be doing over the next several months is to understand the role of LP-little a in South Asians.
That's huge. That's so exciting. And I'm excited to
I'm excited.
learn more from what you find.
Yeah, hopefully we'll have some data coming out in the next few months.
That's awesome.
It's
Dr.
fantastic.
Afak, what about you?
I know that's fantastic. Great to hear that because that will really impact what we do in our practice as well. So that's fantastic. I think more just from as I'd mentioned before, I think, look, just making it clearly established because everyone sees patients of South Asian heritage, just to know things that, waist circumferences and BMIs, just know that there should be a clear kind of flag that highlights that these are out of range. These are out of range for your South Asian patient, and let's act upon it. So I think that that's something which still we can do better on. Um, but
For sure. And the last one, we're going to tie it back to food because food is a big part of the South Asian culture and I think a big part of a lot of our upbringings. One thing that if you could make one switch in the kitchen for family members, patients, people that are listening, that's a very overlooked dietary contributor. We've kind of touched upon this on a couple of our series for Diwali and Ramadan a little bit, but what is your big one swap you would recommend? And we have more coming, obviously, from SAPNA related to this, but
if we can, I'll say there's so many things that I think we could touch upon, but you know, just how can we? I think the South Asian diet is very rich in refined carbs. So how do we change that food category? So whether it's rice is a big thing. Is that can you switch from white rice to brown rice? Is that something which is just doable as a small sustainable change? I'm big in small changes which are sustainable rather than dramatic differences. Be my thing.
I love it.
I would pick saturated fats, things that are fried and things where we add a lot of butter or ghee in preparing our, meals and including our desserts and sweets. I think maybe, I guess if you eliminate it, then you won't get what you are looking for, but maybe decreasing the amount significantly, I think could go a long way. Actually would align with what Mazhar mentioned, that something that is small but sustainable, where you kind of would not be able to eliminate it completely, but decrease the amount of saturated fats that are added to the foods that we consume.
And I think the moderation approach and not, because I feel like when we talk about the dietary stuff, and we'll get into our next question with that, but the challenges that come with diet counseling is that sometimes there's this misconception that it's all or nothing. And then people feel very restricted by your recommendations rather than let's meet you where you are and take those steps slowly. And so on that note, what challenges do you face with diet counseling and how do you kind of try to explain to your patients? Because I talked about this briefly in another episode, but the paper printout with the plates, and we've kind of moved away from that a little bit, but when we tell people a recommended diet, I often think of Brussels sprouts because I didn't eat Brussels sprouts growing up, and I don't even know if I would know how to cook them. They're usually smothered in sauce, but I think sometimes some of the things that we recommend people swap, they don't even really eat in their household, and especially when I think about a South Asian diet. So in that note, I'll turn it over to the experts for how you counsel patients related to dietary modifications, which we know is a huge part of preventing and managing your cardiovascular risk. And we'll start with Dr. Afak.
I still use, we start with the foundation of a Mediterranean style diet. I might use that as an example to build upon, right? I might ask them, what are some of your, regular foods? I might say, well, what did you eat last night? Or what was for dinner? And really to focus on, uh, reducing intake of meat. I think one thing you'd mentioned as well before, the South Asian population is still very diverse within that population. And I think there's lots of vegetarians, there's also heavy meat eaters, so I remember growing up, if there wasn't a meat dish cooked as part of your daily meal, it was like, oh, because we didn't have any meat. It wasn't like it was hey, we're being conscious. So, the fact that when we had like lentils and rice, it was a rarity. It was like, oh, that's unique, right? Now, I think we do focus on the importance of there is protein intake, and that protein, whether it's, Anurag mentioned chickpeas, that lentils, those kind of things. Still changing out in those patients who eat fish as an important source of protein as well. Again, how do we talk about reducing salt, reducing fried foods. People will relate to, the frying. One thing I've definitely taken note of that were for during visits is that do not, if you're frying, definitely don't refry. Because there used to be a thing, looking back to my childhood, there was like a pot ready to fry things just left on the stove.
For sure.
Yeah, and refrying is I just don't think it was recognized that how bad that is. And again, as you mentioned, changing out white rice to brown rice, something, just giving suggestions of that. I think the best thing really would come from is that, because we refer our patients to our nutritionists, right? But having more nutritionists who are well versed in that diet and the kind of foodstuffs that people would like. And I think as we get more awareness, that's also going to happen too, I think.
Yeah, that's a good point. The cultural sensitivity aspect of it, so that when swaps are being offered, they're offered for things that people are used to eating. Um, Dr. Mehta, what do you think?
I would completely agree, especially like the dietary recommendations being culturally competent. And as mentioned, it's a very broad group, South Asians, and some people are vegetarians, some people are not. And then within non-vegetarian, there's a preference for the kind of meat that they consume. And understanding what the dietary preferences are for a given patient, I think goes a very long way. Something that I feel I personally use and also recommend is portion control. And also something that Maz alluded to earlier during our conversation is trying to keep an eye on what goes in your mouth. I know that, sounds very simple, but helping people understand, what they are consuming, what's the amount of sugar in it, what's the amount of saturated fat in it, and trying to limit that and kind of shuttle towards, for example, snacks. You can use Mediterranean style nuts, legumes, and seeds instead of consuming mithai, for example, with your tea. Or, something that I used to do a lot growing up was these biscuits, which are just laden with carbs. There's, you guys might know it, Parle-G. There's like this brand, just like super,
1000%.
yes, super old. Every home has like, I think, 100 packets of Parle-G biscuits. And just, making those little swaps that when you're having your morning tea or your evening tea, instead of having a packet of Parle-G, you can have like nuts instead of, you can have some almonds with it, some cashews with it, pistachio, etc. So those kinds of little tricks, but those do require an understanding, a very well-versed understanding of the culture, the dietary preferences, understanding what your patient actually does on a day-to-day basis, and then making these adjustments. So having nutritionists who are well-versed in the South Asian dietary preferences, I think, goes a very long way.
Yeah, absolutely. And so we talked a little bit about the challenges, and now I kind of want to shift to what things have worked at a community-based level. What community-based interventions, education programs have you both seen, whether that's at your institution or just you've learned about through kind of hearing about these community-based interventions? And what do you think we can learn from them as we try to format maybe our own type of community-based intervention at our institutions? And we'll start with Dr. Mehta.
Keerthana, for this, I'd like to give a shout out to the Saheli trial, which is based out of Northwestern in Chicago, kind of a community-based intervention like you were mentioning. I think something that can go a very long way, and which is true for human beings in general, not just South Asians, is that if an intervention is deployed in a manner where there is buy-in from the community, where people feel supported by their friends and family when they are making a particular change in their lifestyle, their, diet, I think that goes a very long way. It is so subtle that I sometimes have to look back and see why I did this, and I would realize that, oh, my best friend did that, and that kind of, had like an impact on me and made me choose this. Or, for example, going to the gym on a particular day where I just didn't feel motivated to do that. So in my mind, interventions, be it dietary, be it physical activity, muscle strength training, developing programs that are culturally competent, where you can get a buy-in from the community. And perhaps something that can go a very long way is that community leaders, people who are trusted by the masses, if they can endorse those things, I think that has a significant buy-in. For example, this is like I guess, not a very relevant cardiovascular disease example, but when I was younger, living in India, there was the Pulse Polio campaign where you would have celebrities endorse the oral polio vaccine. And I think that did an amazing job, in addition to the community outreach that was done to a point where India eliminated polio a few years ago. So if you are thinking about dietary changes or activity, those kinds of things, I think, can go a very long way.
Amazing. Lots of good ideas there, I think.
I would say is that there's a few things certainly we've become more aware of as well. Certainly as our own, people with interest in South Asian prevention. We're building on what has already come. There's great programs in. I think Kaiser did a study which was a 2-hour educational program, and that showed immense benefit. Again, if you have people like community, people like learning things together, having that accountability, and a 2-hour kind of educational class, and again, culturally specific education had shown improvement. The South Asian Heart Center in Al Kamina, that has done tremendous work, and they have this program which is I think something which really could be grown and emulated in other areas, and that's the AIM Prevent. I've been very impressed with looking at how they function. That's using, again, assessing like patients and having that longitudinal follow-up, so again, people like to have that. This is the benefit of having regular follow-up appointments with your provider. Part of it is that accountability, because we do all fall off the bandwagon. We do, become less strict I definitely think that you become less strict as the time goes on from the time of the appointment, and then in preparation with the appointment, you start getting better again so that you can tell your doc that, yeah, I'm still doing what I said I did 6 months ago. But I feel that those are good things. We did something just locally on a very small scale before Ramadan. My wife, she actually does internal and integrative medicine. So she and my son, who's a high schooler who decided to become a personal fitness trainer so he's qualified for that. So that combination of an internal integrative medicine provider, a personal fitness trainer, and myself as a preventive cardiologist, we got pre-Ramadan kind of education for some of the community. We did kind of pre-weights. We did an educational series, and it was just a month long, and then looked at the post-weight. It kind of showed and then the feedback was just really, really positive. People felt engaged, they felt motivated. And that's really the kind of thing, is that if you can do things it doesn't have to be a huge scale, because then that spreads out. And then people will continue to share that knowledge. So, and that's one of the hopes that we have with our, SAPNA group, as well as our organization, that how we will kind of continue to spread those kind of seeds of change.
What a perfect segue into my next question, which was going to be, what were your goals for the SAPNA group at the ASPC? We've done a couple different campaigns for Diwali and Ramadan, and we've talked about other social media initiatives, but I'll let you kind of continue your train of thought there, Dr. Afaq, with that question.
Well, first of all, I have to thank you for your input and really carrying these, I don't know what the correct term for them are called, these shorts or whatever. I'm not on social media, but they're just fantastic, and couldn't do it without you.
Well, thank you.
You certainly show the rest of us how it should done. After I had my oculomotor nerve palsy, looking down and left without my whole of my my visit. But anyway, I'll tell you, I think and I'm so fortunate to have a partner in Anurag, is that we had just been introduced last year. And again, this is credit to ASPC leadership, is that we were introduced at last year's meeting, and I'd actually had this idea in 2024. I was looking back, I'd actually sent a friend of mine a text to say, hey, what do you think about creating this, right? And I was like, didn't really go anywhere. We're all busy, right? And then, life just carries on. And then I met with Anurag, and then it's just like, he's just fantastic. It's just like, let's get things done. It's like, very much of a doer and just full of good energy. And when we got together, the point was, and we've got a great group. I mean, there's, I think, Anurag, is it 60 now, people, roughly?
Yeah.
I think.
Yeah.
And
It's growing fast.
Yeah, it really is. And the beauty is that when you look, these are from medical students to medical residents, cardiology fellows. There's internal medicine docs, people with specialty in behavioral medicine, and then cardiologists, all the way from prevention to interventional. So it's a really good group of people, and our idea was to really let's make the risk that exists with South Asian patients population. Let's make that known, and let's make that something that we can intervene upon. Let's make that something that we can educate people on, we can really do research on, we can innovate, change our community, from a community setting. So many different things. It wasn't achieve one thing, but it was a very much like, if we can create a community of like-minded people, this will stay long after we're gone, so, and if you can have that impactful change, I think it's good. Somebody had given me a fridge sticker once. I think John F. Kennedy had said it takes one person to make a difference, so everyone should try. And if this is our kind of difference, I think we're doing a good job. And but I'm glad to be working with all of you on this.
Dr. Mehta?
Well, I think first of all, Kirtana, I consider myself very lucky and I'm very grateful that I'm partnering with Maz on this initiative, the SAPNA group, and also extremely thankful to you for spearheading the social media platform and all the work that we're doing with the shorts and the videos and the educational materials. This is something that I've been passionate about for a long period of time. I think it stems from my family history of cardiovascular disease. And as Maz mentioned, I feel like I'm somebody who just like keeps on knocking doors, bugging people so that, I understand that for every 100 knocks you make, one door will open. And the approach has been one where I think I completely agree with Maz that if this is an initiative that is to last way beyond, us being there for this initiative, we have to connect. We have to be facile. Our strategy has to be such where we connect with like-minded people and, form these partnerships and these relationships where we can help educate, just keep reverberating this message of cardiovascular risk, cardiometabolic risk in South Asians. What can be done from lifestyle perspective, diet, exercise, when you should seek care, what kind of investigations you should undergo, and what kind of things that you can do in order to live longer and healthier lives. That's kind of like the central core. But I do realize that in order for us to grow, the key would be to have a strategy where we are just connected with many, many people who are doing similar work. I would use this opportunity to give a shout out to two of our partners. One is the Our Health study, which is based in Boston. It's being led by Roman Bhattacharya and Pradeep Natarajan, trying to understand the genomic basis of cardiometabolic disease in South Asians. Been done before. People generally don't participate in these studies. So a big shout out to them. They're our partners at SAPNA. And also the Hriday Amrit Foundation, which is a youth-led organization based in India, who are just doing a tremendous job in terms of getting the message out because the population is enormous. 1 in 4 people, 25% of the population is South Asians, most live in South Asia. So just getting these messages out there. And I definitely want to give them a big shout out. Amanpreet Singh Wasser is the lead for that. And the vision is exactly as Maz mentioned, to create something that outlasts us, that grows through other people. And just consider myself to be very fortunate and lucky to be supported by the ASBC leadership, and also in many ways proud of the work that we're doing to help others.
Yeah, I mean, I think for a lot of us, myself included, thank you for the compliment, but there wouldn't even be a space to do what we were doing if you both hadn't created it. And I know for a lot of us, we were kind of seeking an additional spot to grow. We all kind of are interested in this topic and wanted to do something. And I think bringing that community together is huge. And then when we put our heads together, the things that we're able to do is really incredible. But that's all thanks to your leadership. And so very happy to be a part of that and continue to grow the organization. Small pivot here because I would be remiss if I didn't ask this question. A little bit of a step back to the clinical side of things, but South Asian women, are there specific things patients need to, I guess, are there specific things clinicians, not patients, but are there specific things clinicians should be asking for South Asian women in particular? And is there any difference in your approach for them and what do we know about kind of their cardiovascular risk? And we'll start with Dr. Beth.
I think, Keerthana, something that is, I feel like this is the intersection of two important spaces within cardiovascular medicine. One is women's cardiovascular health and South Asian cardiovascular health. In my clinical practice, I, number one, uh, pay a very close attention to atypical symptoms of cardiovascular disease, something that can be very easily ignored in women in general, particularly in South Asian women. So, excessive fatigue, new onset swelling in their legs or ankles, episodes of paroxysmal nocturnal dyspnea, atypical anginal symptoms. I pay a very close attention to that when I'm eliciting my history. The second thing that I pay pretty close attention to is their obstetric and gynecologic history in terms of, um, pregnancy-related complications. Something that is very common in South Asian women is gestational diabetes. So I always ask them about if they've had that issue, and then looking at the development of cardiometabolic risk factors during the post-pregnancy period, and then very important in the menopausal transition period as well. So I think that is where I pay close attention. One would be eliciting history for clinically apparent cardiovascular disease, which, other people might just and think that this is nothing. And then the second would be understanding the life course in terms of the risk factors that they've been exposed to.
Great. Thank you so much, Dr. Afaq.
I think I certainly echo what Anurag said there. And the South Asian women patients that I see tend to be older. And they are at a stage of life where worry is a big factor in their overall, and whether they're worried about kids about to get married or about to have their first grandchild, something, they are often, and this is, I think, across the board, women often tend to be the carers, so they are the ones who are just so busy looking after everybody else that then it comes to, you really have to listen when something is not right, because they've probably delayed it for multiple weeks or months for them to present with something. So those are from the acute standpoint. And again, looking at atypical symptoms, super important. The thing that I would say is that when it comes to just making it okay to be a little bit selfish, focus on yourselves, just really do prioritize. I'll often hear somebody say, but I do housework. And I said, housework is not exercise. Yes, it's good to stay active, but please just dedicate some time for yourself, which is not doing that. It's the same thing when I hear people say, but I walk a lot at work. Just, the importance of doing, again, resistance and cardio. And I would say is that stress is a big part. Stress is a big part of risk for cardiovascular health. And I think if we are going to tackle the whole picture, that has to be part of the conversation too. And let people be vulnerable, let people be in that safe space to talk and say, all right, so how do we deal with this? Because it's often not talked about, certainly in the South Asian population, of the impact of stress, because you're just meant to, just get on with it, just keep going. And we know that that's not good for the heart. And so that's some of my thoughts on that topic.
No, and I think, we could have a whole episode on that specifically. We've talked about that those are the intersection of two big topics in cardiovascular disease. But the point that you made about, culturally, South Asian women, at least when I think of the women in my family, are very much kind of so focused on the family that they really don't stop to think about their health. And the stress component is huge, especially I guess in my household, I'm thinking like me and my brother both got married in the last 3 years, and I'm like my poor mom. I think about the fact that they just kind of keep going and they just keep going, and they really don't take any time to take a step back and think about what's going on in their health unless we bug them and force them, which I'm learning that I seem to not be the only person who does that. And so you know, we've had such an incredible conversation, and I kind of wanted to close with, SAPNA from the heart. So, what is your last from the heart message for the South Asian community as clinicians, as family members, as, the co chairs of the group? And we'll start with Dr. Afik.
I would say there's actually lots to say. So there's so much to say. And I would say, because when I think of South Asians, when I think of family members to friends to patients to, there's the sort of South Asian physicians, So one thing I'd say to you is that like there should be a lot of expertise on this topic amongst the providers that you see. But I think what I would say is that what comes to mind is because there's that whole range of ages is that, look, enjoy your youth when you have it before you get old, and enjoy your health before you get ill. So that means staying focused on these things from the get-go. You're not too young. Our screening for heart disease, certainly in South Asians, is younger. As Anurag mentioned, the calcium score at a younger age potentially, right? So than what's standard, routinely said. So I would say is that really it's never too late to change, and even small changes make a big difference. And so that would be some of my from my heart messages.
I love it. Dr. Mehta?
I would say, Keerthana, something that I experienced a few weeks ago, and we were hosting the screening of a documentary called The Brown Heart. at Emory in Atlanta. And, it's a beautiful documentary. It's available on YouTube. So for listeners, if you want to go there and check it out, it talks about exactly what we are talking about through real life examples. But something that came up at the end of the documentary, which I thought was extremely provocative, and I had never thought about it myself, was that living to 100, which in terms of cricket is a century of runs in cricket, that's your score. And the thing that came up was that scoring a century should be your expectation as a South Asian, which is very different from the kind of mindset that we have in terms of our life expectancy. It made me think back to when I was young, and I would feel like, maybe living to 60, 70 would be a great idea. That would be a good life. But just, that has changed obviously over time, especially living in this country. But that conversation sparked me to think that if all of us collectively as South Asians start to think that, okay, I need to invest in my health as early as possible with diet, physical activity, meeting the clinicians, taking care of, everything, all the risk factors, then we should be aiming towards hitting a century, reaching that 100-year mark in our life. And that would be my message from my heart to everybody who's listening, that we should all become active participants in our health and do good care of ourselves. And like Matt said, it's never too late. Small changes have really big and incremental benefits.
No comments from those closing. I feel like we covered so much in today's episode. We really just scraped the surface, right, of our understanding. We're continuing to learn at a rapid pace about South Asian cardiovascular health, but so much to come from the SAPNA group at ASPC. Really lucky and happy to be a part of that and for both of y'all's leadership, but also just for a really interesting discussion about a lot of different things, because there really is so much nuance to counseling patients and understanding their health, and especially in this particular category or subgroup of patients when a lot of the times there are family members, which is a whole battle in and of itself, which could be a whole episode, I suppose. But thank you both so much for taking the time to talk about a really important issue. And for people that want to learn more about SAPNA, you can go to the ASPC website and join the working group under the incredible leadership of Dr. Afaq and Dr. Mehta. Thank you both so much for taking the time today.
Thank you,
Fantastic. Thank you.
Thank you, Anurag.
Thank you so much for listening. To learn more about the ASPC, please visit our website at aspconline.org.